You know that the lifespan of a red blood cell is 90 to 120 days. That means after 3 to 4 months, the red blood cells are destroyed. And why the red blood cells lifespan is short? Because you know that red blood cells don't have nucleus, right? So nucleus is called the control center of the cell. You have learned that from NP1. So if there is no control center, also red blood cells lack mitochondria and other important organelles. So the important functions are not processed there. So their lifespan is short. After 90 to 120 days in circulation, the cell membrane of the red blood cells become very weak and fragile, and the rupture of the cell occurs. Most of the red blood cells, when they get old, they are taken to the liver or spleen and are destroyed there. That's why the liver and the spleen, those two organs where most of the red blood cells are destroyed, are called the graveyards for the red blood cells. Graveyards for the red blood cells. And inside the liver and the spleen, there are many macrophages, phagocytic cells, and macrophages engulf the old red blood cells, and you know that inside the red blood cell you have the hemoglobin. So hemoglobin has two parts, heme and globin. So after the destruction of the red blood cells, those two parts of hemoglobin get separated, heme and globin. So those two parts of hemoglobin get separated. Okay. Now, the heme consists of iron and other chemicals. Okay. And globin is actually protein, so it is formed by amino acids. You know, protein is formed by amino acids. Okay. So they get separated, and just know that the iron part of heme and the amino acids, these two components go back to the bone marrow. They go back to the bone marrow to produce new hemoglobin. So they are recycled, used again. Iron part of heme and the amino acids. So they will be reused, used again to produce new or synthesis new hemoglobin. We'll talk about that later. Just know that that's what happens. Yes.
So, the liver is what creates the red blood cells, but also destroys them?
Yes, that's right. Yeah. Both. Liver creates the red blood cells only in very early life. So, but destruction occurs throughout the life. Okay. Only in fetus, liver produces the red blood cell. Then the red bone marrow. Spleen also produces some red blood cells in early life. Hemoglobin. Hemoglobin is the red pigment that gives the red color of the red blood cells. and the blood. Hemoglobin is responsible for the transportation of oxygen and carbon dioxide. So, transportation of gases. Now, the normal concentration of hemoglobin in adult male is 14 to 18 gram per deciliter of blood. Deciliter means 1/10 of a liter, that means 100 milliliter. Makes sense? 1 liter is 1000. Now, the question is why in females the amount of hemoglobin is less, because you already know that if you take same amount of blood from a male and a female, the number of red blood cell is more in male, right? So the amount of hemoglobin is more because the number of red blood cell is more. Hemoglobin is more. Okay, so in female the amount of hemoglobin is less. You know that testosterone stimulates the production of red blood cell in male, uh, so number of red blood cell is more in male body. Hemoglobin molecule, you have 4 hemes and a globin. You see those round orange color, those are heme, and the tube-like structures, that's the structure, that's the globin. Now, each globin has 4 chains, 4 amino acid chains. You know, globin is protein, so amino acid. 2 alpha, 2 beta. So 4 amino acid chains. You see here in this picture, alpha chain 1, alpha chain 2, beta chain 1, beta chain 2. So 4 chains in globin. That is the structure of a hemoglobin molecule. Now, you see here, I told you that heme consists of an iron and other chemicals. So if you see the picture here, you see this is the heme chemical structure. So iron in ferrous form, remember iron must be in Fe2 plus. This is ferrous 2 plus, not 3 plus form. This iron Fe plus 2 can carry or transport oxygen. If the iron is in ferric form, iron could be also in ferric form, that means 3 plus. That is not good to transport oxygen. So in the heme, the iron must be in ferrous form. Anyway, so you see the iron and other chemicals. Okay. So that is the structure of a heme. And globin consists of amino acids. How many chains? 4 chains. 2 alpha chains, 2 beta chains. Okay. So that's the structure of the hemoglobin. Okay. Now we'll see the fate of the hemoglobin. After the red blood cells are destroyed, hemoglobin comes out and the heme and globin get separated, right? You know that these two components get separated. And I have also mentioned that the iron and amino acids, they will do what? Will go back to the bone marrow to produce new hemoglobin. So they will be reused again and again. Now what will happen to rest part of heme? The other chemicals or rest part of the heme will be first converted to biliverdin, and then biliverdin will be converted to bilirubin. So just know that first the other chemicals or other part of heme will be converted to biliverdin, and then it will be converted to bilirubin. You know, bilirubin is the yellow pigment that if bilirubin accumulates in your body, jaundice, yellow coloration of the skin and mucous membrane occurs, right? That's the jaundice. So bilirubin is continuously being produced because red blood cells are dying continuously in our body. So bilirubin is being also produced continuously, and that bilirubin will go to the kidneys and to the intestine and will get out from the body with the feces and urine. Make sense? So what's the color of bilirubin? Yellow pigment, and that's why since they get out through the urine and feces, the color of urine is slightly yellowish. You know that, right? Because of the presence of bilirubin, and also the feces, color of feces is yellow because of that. Now, if for any reason the bilirubin cannot get out from the body, then what will happen? Inside your body, the bilirubin will increase, built up, right? And that will give the skin color yellowish and mucous membrane yellowish, and that is the jaundice. So jaundice is the increased concentration of bilirubin in the body. That can.
So common with infants.
Yeah, that is a physiological jaundice. That's not harmful. We say when after you'll see birth, infants often get jaundice, right? It stays for a few days. That jaundice is called physiological jaundice. Physiology means normal, right? In a normal function. So that is not harmful because mother's blood still remains in fetus body, and those red blood cells keep destroyed because
So
those
why
are
do they
old.
put them under the UV light? If it's
Yeah, that will stabilize the cell membrane of the red blood cell. Amino acids will also go back to the bone marrow to produce new hemoglobin or red blood cells. But rest part of heme will be converted to biliverdin and then bilirubin, and will go through the liver, to the kidneys, and to the intestine, and will get out to the feces and urine. So that's the fate of the red blood cell or hemoglobin. Same thing. A couple of clinical conditions. Hemoglobinuria is the hemoglobin breakdown products in urine due to excess hemolysis in the bloodstream. So, if the red blood cells are destroyed too much, destruction of red blood cell occur. That means premature destruction. We know that the lifespan is what? 90 to 120 days. But if the red blood cells die before that, and more red blood cells die in the body, in the blood, or destroyed in the blood, that will cause hemoglobinuria. Hemoglobin breakdown products will be found. And hematuria, if you find intact red blood cells in the urine. So if you take a drop of urine and examine under the microscope, you see intact red blood cells there. In that condition, we'll say hematuria. This usually occurs due to the disease in the kidney. The kidney cannot filter. Kidney should not let the red blood cells get out, but if the filter gets bad, then the red blood cells can get out from the body. Now, I told you that obstruction or liver disease will cause jaundice, right? Obstructive jaundice. Another jaundice is called hemolytic jaundice. Excessive breakdown of red blood cell will produce more bilirubin. Make sense? Hemolytic. Hemo means blood, lysis means breakdown. Hemolytic. Yeah. So, one is obstructive jaundice, that is due to the obstruction of biliary tract or bile duct. Another is the hemolytic jaundice. In this case, you see, your excretion is normal, okay, but too much breakdown of red blood cell is being occurred. So what will happen? More bilirubin will be produced. So the blood level of bilirubin will stay high. So that is another type of jaundice. Uh, in infants, physiological jaundice, that is a hemolytic type jaundice because the breakdown of mother's red blood cell, right? Breakdown. Okay, so now we'll move to the part 2 of the blood. Slow.
Did you try opening a new window, right click it? Sometimes that goes through.
It will do the same. Poof. Okay, come. Okay, so in this part, we'll first talk about the erythrocyte disorders. That means disorders in red blood cells can cause what kind of problems? Then we'll talk about one type of disorder that is very commonly heard. That clinical condition or disorder is called the anemia. So we'll talk about different types of anemia. Then click too many times. That's right. Okay. Then we'll talk about the white blood cells. First, we'll see the properties of white blood cells. Then we'll see different types of white blood cells. Then we'll talk about also some disorders of white blood cells. It's not listed here. Then we'll talk about another type of blood cells, thrombocytes. Thrombocytes are also known as platelets, right? Platelets or thrombocytes. We'll see the functions, properties, and then we'll talk about the coagulation of blood or blood clot formation. Then we'll talk about the blood types or blood groups. Erythrocyte disorders. Anemia is a commonly heard erythrocyte disorder. Anemia is the condition in which the blood has abnormally low oxygen carrying capacity. So, blood carries less amount of oxygen, less than normal. Then, why anemia is harmful? Because you know that oxygen needs to be taken to the tissues. Tissue needs oxygen for metabolism. If oxygen is transported less than normal by the blood, your tissue will not get enough oxygen for enough metabolism. And we know that metabolism produces ATP, right? You know that. That provides energy. So if your body doesn't get energy, then what will happen? Fatigue, extreme tiredness, paleness, shortness of breath, and chills. Those are the signs of anemia. Definitely, lack of energy will cause the extreme tiredness, lack of hemoglobin or red blood cell you know that red blood cell or hemoglobin gives the red color of the blood, right? So if you have less red blood cells or hemoglobin, the color of the skin or mucous membrane will get less red, right? So that's the paleness of the skin and mucous membrane because of less number of red blood cells or hemoglobin. Shortness of breath. The person will get tired easily and will get hungry for air. And chills. The, the person will be more susceptible to cold. Now, we classify the anemia in different groups. First, insufficient erythrocytes can cause anemia. That means in your circulation, the number of red blood cell is less. That will definitely cause anemia or decreased oxygen carrying capacity. How in your circulation the red blood cell count can go down? Number one is hemolysis, breakdown of red blood cell, and that is called, sorry, no, not hemolysis. First is the hemorrhagic anemia, bleeding. Hemorrhage is the bleeding. So if excess bleeding occurs from the body, you lose blood, then the number of red blood cell will definitely go down because red blood cell will get out from the body.
What would cause like an acute? I can see a chronic, I've heard of chronic, where that's the physiology.
Right. Hemorrhage, yeah. Hemorrhage could be acute or chronic, right? Blood loss. Now, acute loss is accident. In road accident, if you got a big cut, then bleeding will occur, right? Sudden loss. Acute means sudden, quick loss of lot of blood. So that is an example of acute hemorrhage. Another is major surgery, big surgery. We lose blood, right? So that's acute loss of blood.
We're
Right?
not
So
looking at the cause, we're looking at the state.
okay. And chronic bleeding, if you get an ulcer in your stomach, ulcer, small amount of blood will leak out, right? Continuously. Although very small, but for a long time, like it happens for years or months, then a lot of blood will get out eventually. So that's an example of chronic loss of blood. Another is worm. Worm in the intestine, intestinal worm. They love to stay there inside this intestine for a long time, and they will suck the blood, right, from your body. So you lose blood for a long time, a small amount, but a lot of blood will be drained out. So that is the chronic loss of blood. That will decrease the count of red blood cells. And number two, another is hemolytic anemia, lysis, breakdown of red blood cells, excessive breakdown of red blood cells. If that occurs, then anemia, the number of red blood cells will go down. Aplastic anemia. If the site of production, that means the red bone marrow, is destroyed or depressed or become inactive, that will decrease the production of red blood cells. Makes sense? So the count of red blood cell will stay low because the red blood cells are not producing, the bone marrow is not producing enough red blood cells. Now, how the red bone marrow can get inactive or depressed or destroyed? There are many reasons. One is drugs, some medicines. If you take for a long time, that medicine can depress or destroy the bone marrow. Okay, that's the toxic effect of drug. Another is excessive radiation. If someone goes through too much radiation, then that can depress the bone marrow. So those are two main causes of the bone marrow destruction. High dose of antibiotic, particularly penicillin, can destroy the bone marrow. So those are the anemia due to insufficient red blood cells. Now, anemia can also occur due to low hemoglobin content. Although the number of red blood cell is normal, but the amount of hemoglobin is less. That will also cause decreased oxygen carrying capacity, because we know that the hemoglobin carries oxygen, right? So if the hemoglobin amount is less, that will definitely cause anemia. The two conditions here, you see, one is, this is your normal blood, this is anemic blood. So one is, this person, normal person, has this many red blood cells, okay, and this person has this. That means what? Less number of red blood cells. So this is definitely anemia. Make sense? Low or insufficient red blood cell will cause anemia. Now another thing is, this person has same number of red blood cells, 9. But you see, the hemoglobin in these red blood cells is more than the hemoglobin in these blood cells. Make sense? So although the number of red blood cell, if you count the red blood cell, same, right? But the amount of hemoglobin is less here. So the oxygen carrying capacity will be less here. This is the condition, low hemoglobin content anemia. Okay. So two types of low hemoglobin content anemia we see. One is iron deficiency anemia. We know that iron is a component of heme. So if you have iron deficiency, then that will not produce enough hemoglobin, heme part of hemoglobin. And another is pernicious anemia, that occurs due to lack of vitamin B12. Vitamin B12 helps in the synthesis of hemoglobin. When the hemoglobin is produced, vitamin B12 helps in the synthesis of vitamin B12. So either iron, lack of iron, or vitamin B12 will cause the less synthesis of hemoglobin. So the red blood cells will get less amount of hemoglobin. Just know that those are the two main reasons that will cause low hemoglobin content anemia. Another is abnormal hemoglobin. Now you see that you have same number of red blood cells, and this blood has healthy hemoglobin, but in this red blood cell, these red blood cells have abnormal hemoglobin, like sickle cell anemia. The hemoglobin shape changes. Although the amount is good, but unhealthy hemoglobin, abnormal hemoglobin. So this is, for example, sickle cell anemia. Hemoglobin is there, a lot of hemoglobin, but these hemoglobin are not useful, useless hemoglobin. One abnormal hemoglobin content anemia is called thalassemia. In this condition, the globin part of hemoglobin is faulty. You know that the heme and globin. Those are the two components of hemoglobin. So in this case, the globin chain is faulty. Okay, that is called thalassemia. And another condition of abnormal hemoglobin is sickle cell anemia. In this case, the hemoglobin will become hard. Normal hemoglobin is soft. This hemoglobin will become hard like crystal like hemoglobin, and sharp like sickle. Sickle is that tool, I don't know if you have heard that sickle, that tool that in old time farmers used to use to cut the crop. So sickle, both ends are pointed in this hemoglobin, and when the red blood cells will try to pass through the capillary, the sharp, hard pointed end will destroy the cell membrane. Okay, and this hemoglobin cannot bind with oxygen hemoglobin. Okay,
So you
that's
have to have the gene to get sickle cell.
second.
To get sickle cells, you have to have the gene.
Right, abnormal gene. Yeah, abnormal gene. So that's hereditary. It goes from the parents to the offsprings. Okay.
Do you still think it's
Okay, so it could be, but it occurs more in African blacks. That's probably their genes are more sensitive to the malaria, and that can probably modify that. Yeah, that can happen. Okay, so those are different types of anemia and their causes. Now, another red blood cell disorder is polycythemia. Polycythemia is the abnormal increase of the red blood cells in circulation. So if in your blood the number of red blood cell is abnormally high, that is called polycythemia. So it is just opposite of anemia. In this case, the viscosity or thickness, you remember I said viscosity is the thickness of the blood. So the viscosity of the blood will increase, and the blood flow will decrease. If the blood becomes thick, then the flow will get slower. And also, what happens? Circulatory overload. We use the term circulatory overload. When the viscosity of blood increases, pressure on the blood vessel, wall of the blood vessel increases. Make sense? Because of increased number of red blood cell, the volume of blood will also increase, also the thickness. So the pressure will increase on the circulation on the blood vessel. Results from how polycythemia can occur. One is the condition polycythemia, that is called polycythemia vera. This is a disease, clinical condition, occurs due to bone marrow cancer or bone marrow tumor. If bone marrow tumor or cancer occurs, then the bone marrow can multiply the cells faster and produce more red blood cells. And another reason is due to lack of oxygen. And if you know that hypoxia, lack of oxygen, stimulates the production of red blood cells. We know that. We have talked about that in last class. So, if lack of oxygen in the tissue occurs, that will stimulate the production of red blood cell. That is called secondary polycythemia. This is a physiological response of your body. Like if you go on the top of the mountain, right, where you have lack of oxygen. So what will happen? It will happen to everybody. The red blood cell count will increase, right? It will happen to healthy person, everybody. So that's why it is called physiological or secondary polycythemia. Same thing, okay? It will happen to healthy person. not a clinical condition. This is the normal response of your body. And another way you can increase the red blood cell count in your body, that is called blood doping. Probably you have heard this term, right? Athletes, they sometimes do this practice. You can take your blood out from the body and put somewhere, store somewhere, and before the performance, before the event, you can inject it back into your body. So that way the red blood cell count will go up, right? And your body will, blood will be able to carry more oxygen because you have more red blood cell. So your tissue will get more oxygen, your performance will be better. So this is another way, but this is self-induced. This is not actually a clinical condition or normal response of the body. Yes.
Does anything have to be done to that just by continuously blood doping?
Not really, no short-term effect. But if you keep doing that, when you modify your physiological normal function, and if you keep practicing that, that can be a problem. Your body,
Would it
yeah,
adjust to it and
adjustment is a,
make
yeah,
more red blood cells?
right. Your body can get used to that, and when your body will get used to that, in normal amount, body will not be happy. This is normal response of the body. The problem is here, if you do that, there is a good chance of getting other microorganisms or harmful things antigen enter into a body. You must be careful.
So by that time, when your body had made more red blood cells, or when you by blood doping, would you get anemia or any other disease because you're increasing your red blood cell count?
Normally, that will not happen. The red blood cells will die after 120 days, and many of these red blood cells are already, for example, 50 days or 70 days past, right? So they will die, and will the count will come back to normal. So not really, it
Because it's so
affects the
short
body.
term, there's probably not going to be a homeostatic shift.
Okay, so now we'll talk about the leukocytes. Leukocytes are the white blood cells. The white blood cells are mainly responsible for immunity. I have mentioned that before. White blood cell count is 4 to 11,000 per microliter of blood. Okay, microliter of blood, 4 to 11,000. That means 4,000 to 11,000. So you see, much lower than the red blood cells. Red blood cell count was 4 to 6 millions, right? So this is 1,000. White blood cells make up less than 1% of total blood volume. Properties. White blood cells have some important properties. These are physiological properties of white blood cells. Margination, diapedesis, amoeboid motion, positive chemotaxis, and phagocytosis. So what is margination? First, this is the blood vessel. For example, a vein, and outside of this blood vessel, if you get any infection or inflammation, okay, or infection here, so you have microorganisms here. So when that happens, the white blood cells that circulate through the nearby blood vessel, these white blood cells can do what? They can sense that something has happened here. Microorganisms or antigens are here. So these white blood cells will do what? Instead of passing through the blood vessel, they will get attached to the wall of the blood vessel like this, and they will line up that is called margination. They will move to the side and will get attached to the wall. Okay, and that is the margination. And then you know that in the veins and capillaries there are many holes or pores, tiny holes. So what will happen next? The white blood cells will try to get out from the blood vessel. First, it will put a small part out through the hole because the hole is small and pass the fluid from here to here. So this part will gradually get bigger and this part will get smaller and eventually it will come out. Okay. So this process, how the white blood cell squeezes out through the small holes in the wall of the blood vessel, that is called diapedesis. Okay. Then, once the white blood cell is the outside, it will start to move towards the site of infection or inflammation. How the white blood cell moves? They move by producing processes like amoeba. You know that amoeba has the way to move, that is called amoeboid motion. They mix process out from the body and move like this. So the white blood cells will move like amoeba. So that's why it is called amoeboid motion or movement.
Next, once it's outside cell?
Once it is
Or
outside
out
of the blood,
vessel?
yeah. So through the tissue, it will start to move towards the site of action, inflammation. How? Like an amoeba. So amoeboid motion. Now, why the white blood cell will move towards the site of infection, not in another direction? The reason is, at the site of inflammation, you have chemical changes, right? We know that when inflammation occurs, chemical change occurs, right? Redness and other changes you see because of the chemicals. So, the chemicals in this site will attract the white blood cell. That's why it is called positive chemotaxis. Chemotaxis, chemical attraction. So positive chemotaxis or chemical attraction will direct the white blood cell towards the site of inflammation. Now what is negative chemotaxis? Yeah, if this chemical tells the white blood cell, don't come here, go away, this is harmful for you. Okay, then that is the negative chemotaxis, right? The chemical that will inhibit the cells to move. And then when the white blood cell will arrive here, you know that white blood cells do phagocytosis, so engulf the microorganisms. Okay, that is the process called phagocytosis. So those are some important properties of the white blood cells. If I ask you in the test that write down 4 or 5 important properties of white blood cells, you will mention this. If you say that a white blood cell has a cell membrane, I will give you no point. Okay. If you say white blood cell has a nucleus, yeah, I see sometimes students do that. That's the property of a cell, having nucleus, having mitochondria, having cell membrane, right? So that's not the only property of white blood cells. These are the properties of white blood cells. Yes. Engulf. Phagocytosis. What?
Functions, not properties. Functions. This is what they do, how they behave.
Function
Why are you
is,
calling it properties?
these are the behavior of white blood cells, not the function. Behavior is the property. Your behavior is your property, not the function. Function is destroying the antigens. Okay, that's the function.
Put behavioral properties on it.
Physiological property. Physiological. That's why I said at the beginning, physiological properties, not the anatomical properties. Okay. Okay, you see here they have mentioned the count is 4,800 to 11,800. Just know that 4 to 11, that is, uh, we don't need the fraction. Now, there are 5 different types of white blood cells, and we divide the white blood cells into 2 types, granulocytes and agranulocytes. Which ones have granules? Granulocytes. That's why cytes are cells and they have granules. Agranulocytes don't have granules. Granules are tiny pieces of concentrated chemicals, highly concentrated chemicals from tiny pieces or dot-like structures in the cytoplasm. That's the granule. So, what are the granulocytes? Neutrophils, eosinophils, and basophils. What are the agranulocytes, lymphocytes, and monocytes? Now, one simple way to remember is if ends with phils, that is what? Granulocyte. Make sense? If ends with cyte, that is agranulocyte. Why? Phils are at the end of granulocytes because these names have been given based on the attraction, philia. The granules take what kind of dye? Okay, so neutrophils take both acidic and basic. That's why they get neutral. Make sense? Both kinds of dye. Eosinophils only takes acidic dye and gets orange or red color. Acidic dye, eosic. Basophils take basic dye or alkaline. So blue colored dye. B starts with basophil starts with B. So remember purple or blue. If you see the granules take blue or purple color, that's basophil. If you see the granules are red or orange color, that is eosinophil. If you see no color in the granules, that's the neutrophil, a very pale color, because uh, neutrophil granules take both, so they cancel each other. Agranulocytes are lymphocytes and monocytes. Now, most common or abundant white blood cell is the neutrophil. 50 to 70% white blood cells are neutrophils. So if I give you 100 white blood cells, you will find 50 to 70 of them are neutrophils. Second highest is the lymphocyte. Lymphocytes form 25 to 45% count of the white blood cells. So if you count 100, you should get 25 to 45 white blood cells are lymphocytes. Eosinophil, basophil, and monocyte, they are very few in number in your blood. The granulocytes have lobulated nuclei. That means the nucleus has lobes in granulocytes. Now, if you see a neutrophil, you see the nucleus of a neutrophil has multiple lobes. We see 2 to 6 lobes. One nucleus, remember, this is one nucleus, but you see the nucleus is lobulated. It has a number of lobes or pieces. For example, this one has 4. So this is a neutrophil. If you see an eosinophil, usually eosinophils are bilobed, two lobes, the nucleus. And if you see so this is eosinophil, and if you see a basophil, also basophils are bilobed, like this. Now the question is then how you will identify a basophil and eosinophil. I told you that if you see the granules, in case of eosinophil, the granules are what? Orange or red color. Many granules you will see attached to the nucleus. Nucleus is always purple, so don't get confused with that. Nucleus always looks purple. If you see a basophil, you will see the bluish or purple color granules. Okay, so like this. So this is blue. Remember, this is blue or purple. So orange. So that's how you can separate a basophil and an eosinophil. Okay, those are the granulocytes. Now, agranulocytes, let's see here. You see, the first one is a neutrophil. You have to be very careful when you look. You see the granules are not deeply stained, but multiple lobes in the nucleus. So this is a neutrophil. This one is an eosinophil because you see the nucleus. Let's first see the nucleus. This is the nucleus, purple color. It is bilobed, but granules are red or orange color. This is a basophil. You see also bilobed nucleus, and the granules are purple color. So those are the granulocytes. Just know that basophils produce important chemicals. One is heparin and also histamine. Histamine and heparin, those two important chemicals are synthesized in basophil. Heparin is an anticoagulant. Probably you have heard that. Anticoagulant. It prevents the blood clot formation. Natural anticoagulant. Make sense? And histamine is a chemical that is more related to inflammation. Okay? Inflammatory action. So those two chemicals, important chemicals, are produced by heparin. Another thing, just know that eosinophils, there is a condition, clinical condition, that is called eosinophilia. And eosinophil count increases in any allergic reactions in your body. The number of eosinophil increases. All these white blood cells have phagocytic action. They can engulf the microorganisms. They can eat or engulf the microorganisms and provide immunity. Agranulocytes, lymphocytes and monocytes. If you see a lymphocyte and a monocyte, very easy to identify. Lymphocytes have large round nucleus. So this is the nucleus of a lymphocyte, and the nucleus is large, round, occupies almost whole cell. Only a thin rim of cytoplasm is here around. Thin rim of cytoplasm. So this is lymphocyte. And monocyte is the largest white blood cell, much bigger than other white blood cells. And if you see the nucleus is kidney shaped. Kidney shaped or bean shaped nucleus. Okay? Sometimes say horseshoe, but probably not all of you have seen horseshoe, so that's not a good. If you cannot see, then you won't imagine how it looks like. So horseshoe,
monocyte.
Monocyte, yeah. Horseshoe or bean or kidney shaped nucleus. Monocytes are very large white blood cells. Neither lymphocyte or monocyte has granules. That's why they are agranulocytes. One just important information here about monocyte is many monocytes come out from the blood and enter into the tissue and become macrophage. Okay, to become macrophage. FAS. I'll check it. So many monocytes turn to macrophages, and they stay in the tissue and do the phagocytosis. Lymphocytes. Just know that lymphocytes could be two different types: T lymphocytes and B lymphocytes. Okay, T and B lymphocytes, and both of them are responsible for immunity. T cells usually do phagocytosis, and B cells produce antibody.
Is it response to the
AIDS virus destroy the lymphocytes, yes, and immune system. Okay, so T and B cells, but morphologically, if you see from outside under the microscope, you won't be able to tell which one is T, which one is B. Okay, these are functional differences. T cells love to engulf, and B cells love to produce and release the antibodies. That's how they work. Okay, monocyte. We have talked about that. You see here, this is a lymphocyte and this is a monocyte. So monocyte has kidney-shaped nucleus, lymphocyte large round nucleus. Very small space is left between the cell membrane and the nucleus. Okay. So let's stop here. Probably we'll need a little more time to finish the blood in next lecture, then we'll start the new system.